more than just a rash. Imagine waking up to a searing pain on one side of your body, like a fiery ribbon stretching along your skin. Days later, angry red blisters appear, a physical manifestation of something far deeper, herpes zoster, or shingles. This isn't just a rash, it's the result of a dormant virus springing back to life. And while the rash might heal, the pain can linger for months, sometimes years. As dermatologists, we stand at the forefront of managing this complex condition. Today, we're going to delve into herpes zoster, its origins, clinical presentation, complications, and most importantly, how we can make a difference for our patients. Pathophysiology. The sleeper awakens. The story of herpes zoster begins with Varicella zoster virus, VZV, the same virus that causes chickenpox. After the primary infection resolves, VZV retreats to sensory ganglia, lying dormant for years, sometimes decades. Then, the immune system falters. Aging, illness, or immunosuppression creates an opportunity, and the virus reactivates. It travels along sensory nerves, igniting an inflammatory fire that erupts as the characteristic shingles rash. Who's at risk? Older adults, over 50 years, immunity wanes naturally, immunocompromised patients, HIV, cancer, transplants, and steroid use are common triggers. This reactivation isn't random, it's a calculated, opportunistic strike by the virus. Clinical presentation. Signs you can't Mississippi, Phase 1. The warning shot, prodromal phase before the rash appears. Patients often experience burning pain, tingling, or sensitivity in a specific area of skin. The pain follows a dermatomal distribution, offering the first clue. Systemic symptoms like fever, malaise, and headache may accompany the discomfort, adding to the diagnostic puzzle. Phase 2. The outburst, eruptive phase. Here's where the classic rash makes its debut. Maculopapular lesions evolve into grouped vesicles on a fiery red base. The rash is unilateral and neatly confined to a dermatome, stopping at the midline. Common sites, thoracic dermatomes are most frequent, followed by cervical and trigeminal. Within 7 to 10 days, the vesicles crust over, healing over weeks, but not without a price. Post-inflammatory changes like scarring or hyperpigmentation often remain. Pain. The silent burden pain is more than a symptom, it's the signature of herpes zoster. Described as sharp, stabbing, or burning, this neuropathic pain can persist long after the rash resolves, becoming a complication we call postherpetic neuralgia, PHN. Special clinical variants. Beyond the usual. Herpes zoster ophthalmicus, HZO. When the virus invades the ophthalmic division of the trigeminal nerve, the stakes are high. Look for Hutchinson's sign, vesicles on the tip of the nose, heralding possible keratitis, uveitis, or even vision loss. Urgent ophthalmology referral is critical. Ramsay Hunt syndrome. This variant targets the geniculate ganglion of cranial nerve 7. Patients present with a triad, vesicles in the external ear or canal, severe ear pain, facial paralysis, and taste disturbances. These aren't just rashes, they're potential gateways to long-term disability. Complications. When things get serious. Acute complications, secondary bacterial infections of the vesicles, such as impetigo. Neurological threats like encephalitis, meningitis, or myelitis. Chronic complications, postherpetic neuralgia, PHN, the pain that refuses to leave, lasting beyond 90 days after the rash. Risk factors include older age, severe acute pain, and extensive rash. Rare complications, disseminated zoster, multiple dermatomes, or even visceral involvement in immunocompromised patients. Motor nerve paralysis, weakness or paralysis in the affected area. Diagnosis, clarity amidst complexity. In most cases, clinical diagnosis is straightforward, a dermatomal rash paired with sharp, localized pain points to shingles. The unilateral nature and distribution are critical clues. When in doubt, confirm with laboratory tools, PCR, the gold standard for detecting VZV DNA. DFA, a rapid but less sensitive option. Zinc smear, useful for identifying multinucleated giant cells, though it doesn't distinguish VZV from HSV. Atypical cases, particularly in immunocompromised patients, may warrant these additional tests. Management, the dermatologist's arsenal. 1. Antiviral therapy. Timing is everything. Antiviral therapy within 72 hours is key to reducing viral replication, shortening the duration of rash and pain, preventing complications like PHN. Options include acyclovir, 800 mg 5 times daily for 7 to 10 days. Valacyclovir, 1g 3 times daily for 7 days. Famciclovir, 500 mg 3 times daily for 7 days. Late treatment can still benefit severe or immunocompromised cases. Pain management. Pain control must address both acute discomfort and long-term neuralgia, acute pain, NSAIDs or acetaminophen for mild cases, gabapentin or pregabalin for neuropathic pain, short-course opioids for severe cases. Postherpetic neuralgia, first line, gabapentin, pregabalin, or amitriptyline. Second line, lidocaine patches or capsaicin cream. Adjunctive measures. Keep lesions clean and dry to prevent secondary infection. Use calamine lotion or cool compresses for relief. Corticosteroids may reduce inflammation in severe cases but don't prevent PHN. Specialist care for complications. HZO, urgent ophthalmology referral with antivirals and topical steroids. Ramsay Hunt syndrome, early antivirals and corticosteroids improve outcomes. Disseminated zoster, hospitalization and intravenous acyclovir, 10 mg per kilogram every 8 hours. Prevention, stopping the cycle. Vaccination is the most effective tool against herpes zoster, Shingrix, 2 doses, 2 to 6 months apart. Recommended for adults 50 or immunocompromised individuals 19. This vaccine reduces the risk of shingles and PHN dramatically, a true game changer in prevention. Clinical pearls. Lessons from the field. Always assess age and immune status. Younger patients may signal underlying immunosuppression like HIV or malignancy. Early intervention is crucial. Antiviral therapy within 72 hours changes outcomes. Tailor pain management to each patient, as pain is often the longest-lasting legacy of shingles. Screen for complications like HZO or Ramsay Hunt early. Referrals can prevent permanent damage. Conclusion: shingles, simplified but serious. Herpes zoster is far more than just a rash. It's a complex condition with the potential for acute misery and chronic complications. But with timely diagnosis, proactive treatment, and effective prevention, we can transform the experience of shingles for our patients. Let's not just treat the rash. Let's address the pain, prevent the complications, and educate our patients on how to stay protected. After all, every blister tells a story, and it's our job to rewrite the ending. Thank you for watching. If you found this lecture helpful and insightful, don't forget to like the video to show your support. Subscribe to stay updated with more engaging and informative content. Hit the notification bell so you never miss an upload. Your feedback and engagement mean the world to us. Together, let's keep learning and growing. Thank you, and see you in the next video.